Welcome everybody to today's EHRC Samvaad talk. We have with us Dr. Satish Rudrappa from Sakra Hospital giving us a talk on technology in brain surgery. I request Professor T.K. Shrikant to introduce the speaker for the day from welcoming him from EHRC.
It's a pleasure to welcome Dr. Satish Rudrappa to this Samvaad series. Thank you very much for taking the time to address us here. I believe you're either just finishing up a surgery or in the middle of a surgery. We really appreciate that you're taking this time. Dr. Satish Rudrappa is a distinguished senior neurosurgeon in India and internationally known. He is currently the director for Institute of Neurosciences at Sakra World Hospital, Bangalore, and also visiting professor of neurosurgery at Hokkaido University, Japan. He has done his MBBS from Karnataka Medical College, Hubli. He completed his M.Ch in neurosurgery at NIMHANS in 1995 and awarded the gold medal for the best outgoing student. He's pursued fellowship in complex spine surgery from Detroit Medical Center, and he's been inducted Detroit Medical Center, thoracic spine training from Barrow Neurological Institute, Phoenix, USA, and fellow of microvascular anastomosis at Henry Ford Hospital, US. He has been inducted as a fellow of the Royal College of Surgeons, Glasgow, for his outstanding contribution as a surgeon and teacher in the field of neurosurgery. He has been a visiting professor at various universities and has been the immediate past president of the Neurosurgeons Spine Society of India. He regularly gives lectures related to neurosurgery and spine surgery across the world, national level, and has published many scientific papers. And his areas of expertise are a range of things around skull, brain tumors, epilepsy, spinal cord, and so on. I'm sure he'll go into some of this in his talk today. What is amazing is that he's performed more than 6,900 brain surgeries and over 7,800 complex spine surgeries, microsurgeries. So we are really privileged to have a distinguished surgeon like that who's very interested in looking at technology also to be able to address us today. So welcome, Dr. Satish Rudrappa, and please take over.
Thank you for that introduction. Yeah, we are two different fields. I can clearly make out when you're pronouncing the word anastomosis that knows no engineer can speak few words of our medicine, and we cannot speak few words of engineering. So obviously we're in the two different things. The very fact that I wanted to address this audience is mainly because unless there is a platform which is available both for the engineers as well as the doctors and the PhD students, we don't innovate much in this country. And my idea is before I retire, some of the PhD students from engineering background will take up the biology subject in the human science and do the PhD on that, so that we can both contribute to the science, especially in this country with the modern day problems of the world where we are relying more on others. Innovation is the key in the future. And I request every youngster who are listening here, if you want any help from me, you're most welcome. And this is my hospital, which I'm showing you the picture. And I'm always available. And my office will be open for all of you. Today, I'm talking about the technologies of neurosurgery. Let me because I'm more used to, I was telling Dr. Shrikant and Srinath also that I'm used to talking in front of the audience, but the pandemic and the present day has created this problem. But anyhow, I have one question, not to answer anything, but to think in your own way. Imagine a situation wherein someone known to you have a brain tumor. Okay, let me know what goes in your mind. So you can put it on the chat, not a problem to me, and I will go through it later. But this is a scenario. The very fact that I'm talking about the technologies here is how the others perceive us, because most of the neurosurgeons are considered as aliens, and many people think that it's a different field and we come from somewhere else, but not so. We are as good as any one of you here, and because we have put a lot of efforts in here, I can just talk few things better than others. Otherwise, many of you are much more intelligent than me, probably. And I think what is required is the boldness to be in that field where it requires the long hours of work, at the same time putting your effort to learn something. So neurosurgery, everybody, once the brain things happen, I keep telling my residents also that I see an average about 25 patients a day related to the brain, and out of which at least about 3 to 4 will have a surgical thing which is required from my hands. So no patients ever has come and told me that, doctor, I have this, go ahead and operate. Believe me, they would have had a lot of apprehension within them. They always think that whether they'll go back home and see their family after my surgeries, and they come with such a lot of questions because we are working at the intricate organ and the most precise thing which has created the difference between other species and the human being in this world is the brain. So whenever there is a problem related to that, everybody will have a severe apprehension on that. So brain tumor is one such apprehensive thing. I'm sure you would have thought your answers. You put it in the chat. I will see at the end. Okay. So now I'll be showing some of the videos and the pictures here. And as a medical person, we always believe in the privacy of the patients. But whoever has, whom I'm showing here, all of them has given a consent to show it for medical teaching and as well as for the innovation and wherever academic program is going on. And there are myths about neurosurgery. The myths about the neurosurgery, even in the medical community, is that anybody who has the brain problem will have a significant mortality and morbidity if they undergo surgery. That's a myth. I will show you at the end, why that's a myth. And once operated, will have a serious disability is another myth, which will be, commonly goes through in Google and Facebooks, etc., purely because Google is an open source. They would have written everything in general. And as the patients come to us with the general knowledge about the surgery, which creates more problem to them than to the surgeon himself. And people also think that the brain surgeon always do only with the head injury of the main surgeon, but it is not so. In fact, the Forbes magazine in 2000 has mentioned that the most stressful and critical job in the world is neurosurgery, and which occupies ahead of the fighter jet pilot job. It has come from Forbes magazine. I don't know what all the statistical analysis they have done and where they got the source, but this is one of the things which is written in Forbes magazine. So why neurosurgery is complex? Even very fact that I'm talking about the technology here is when I graduated from NIMHANS way back in 1995, I joined the residency program in 1990. 1990, India was not open to the world, and the technology we had were very primitive. But even when I joined neurosurgery, many of my own MBBS classmates said, why are you joining this complex field, which will create more problem to you and to the patients alike. So it's purely because at that time there was no CT scan, there are no MRIs, there are no microscopes available. There are a lot of the technology which I'm using today, none of them are available except one head CT scan, which we used to call it as about 60, 30, it was about 16 slice MRI. That means you will see a 16 slice CT scan where you can see the pixel by pixel as an image of the brain. But to a certain extent, we vaguely could find out where is the tumor and where is the problem. But before that, what we used to do is we used to put a direct needle into the carotid artery in the neck. And the carotid artery, once you put the needle into the carotid artery, we used to inject a complex dye, and the dye will go and shows the artery and the veins within the brain. And the shift of the artery and the brain was one of the predictive elements for us at that time, saying that the tumor might be in and around that. So all the microanatomy of the blood vessels, we used to study so intently that any smallest shift, we used to think that that might be the region in which a tumor or something else was coming up. So it was so vague. Around the world, it was same. In the 1990s, in the US was slightly ahead of us. But an average, most of the world was running on the basis of the angiography. So that has given, that gave a significant problem to all of us in the surgery. And sometime when we open, we'll find, something else there, or the tumor would have been in the opposite side. So complex it was. So fortunately, I grew up with the technology. As I graduated, along with me, many things which has happened. And as of today, in my department, I have the best of the best technology available. In fact, my colleagues who come from US always are envy about me to find out how I have everything on the earth, where we can do any kind of the surgery for the brain. And they also wonder, being a so-called developing country, how we have that. That is the power of democracy. And in a democracy, if you do a good job, if somebody is there, there are investments. So is for our future, research, according to me. So why is neurosurgery complex? Is because of the poor anatomical knowledge. And also, the neuronal cells are considered the stable cell. What is a stable cell? Is the positive and negative energy within and outside the cell is equal and proportionate. Whenever this happens at the micro level, the replication will never happen. So that's why you might have seen patients with stroke. Many of them do not recover completely. They might be able to walk, but that side they will not recover because the brain cells which are already been lacking the blood supply will die, and the neighboring cells will take over its function. So it partially replaces its function, but not completely. So that's why there is a non-replicability. And most neurosurgical procedures are long surgeries, and most of us work long hours. So that's why many of the medical students nowadays, they don't take the neurosurgery, except they're completely compulsive, obsessive surgeons like me. And we too want in the same way, because we work at millimeter distance. Today morning also, I did one awake craniotomy. I'll show you the video of one of the other patients, and where tumor was in the speech area, and ultimately I had to keep the patient awake to make sure that I will not destroy the speech area. And that part of the tumor I had to dissect in a different way. So that requires patience, commitment, and perseverance. So if this is not there, the neurosurgery cannot be done the way normally is expected of by the public. And is technically very demanding, and it also requires, because the technicality is difficult, technology is equally important for us. So I will show you all the technology which we have it. So, and an average, whenever I do the brain surgery, surgeon of my level, not every surgery, every institution will do the amount of the surgeries which we do it. Luckily, my team is one of the wonderful teams in the country. And in the Karnataka, we do the good number of unique cases compared to anywhere else in the country. And two of us are partners in several years, and we do nearly about closer to about 1,200 to 1,300 surgeries per year. But for the COVID, which we are short by 20 to 25%, but every day we are operating, which are mainly the brain tumors and brain vascular problems. Aneurysms and AVMs are called as vascular problems of the brain, and which constitute about 15 to 20%. Trauma is barely 5 to 10%, but it is there, but it usually will be distributed in the peripheral hospital. We too don't want anybody in the middle of the city to come, because they had to be treated at the earliest and safeguard their life. And trauma is the least of our procedures. Similarly, we have different techniques like epilepsy surgeries, which is one of my core things, which recently we started a new program for the public purpose. We are going to do about 30 to 40 brain epilepsy surgeries for the chronic epileptic patients, free of cost. That is one of the social initiative by me for this year. And if you have anybody who's having chronic epilepsy, especially those who are below poverty line, please let me know. So what made the difference in brain surgery? It is mainly by four things. One is improved understanding of the brain anatomy, improved training, improved technology, and as I said, perseveration is the key by anybody. So the training of neurosurgery to do a fantastic job along with it, because the technology will not replace a surgeon. A surgeon, it supplements it to a certain extent, but it cannot completely remove I'm sure even the robo one comes. That's why there is no robotics as of now for the brain surgery. which cannot replace because we are working at the millimeter distance, and literally we work at the tip of our fingers, not even at the wrist level, nor at the arm level. So all our movements are micro movements, and under the microscope, which is zoomed 16 to 20 times, so it requires high precision. The training requires multiple stages. One is the knowledge acquisition, application of the basic knowledge. Altogether, it takes closer to about 10 years in the beginning. And once we get this knowledge of basic skills, we can apply the surgical proficiency, which take another 2 to 3 years. So on average, a good surgeon, you can reasonably good neurosurgeon, I can call, only when he's 10 years after his graduation. And the application is rest of one's career. And we will be learning each and every day. And even today, I remain as a student because I still lot more to learn in my life too about this procedure. So to train, what we do is, the technology we use is a table mounted microscopes. So most of us learned, especially people like me, I had to go to US as a fellow, and there in the Henry Ford Hospital, this is what is a microanastomosis kind of introduction he was giving in a Henry Ford Hospital. We will mount under the microscope the skull head, and we dissect hours together, months together, to understand the anatomy of the brain, because it's such a complex organ. And in neurosurgery, we put the patient in a different position. We have to have a three-dimensional picturization where the tumor will be and how I had to approach that area without causing problem to the neighboring structures. So it is such a soft structure, and all the nerves are exactly equivalent to your hair size. And ultimately, more we touch briskly, more the problem we create. So anatomy learning is the key in that. And this technology of learning is still primitive in India, though some centers are there, not available to everybody. This is one of my core things, to think that from the social responsibility point of view, I am planning to start a technically challenging neuro training center in Bangalore. So hopefully it will materialize when we come across with a cheaper monitor system, cheaper microscope, and which are available and made in India rather than somewhere else, because all these things cost humongous amount, millions of dollars, but we had to look into how to do it further. So what we do is, don't get scared. This is how we get trained. This is one of the heads, fresh head. In US, we used to have the funeral homes will be tied with the medical colleges. And one such institution is my institution. If anybody dies, people donate their organ. And we used to go, and within 24 hours, we had to bring the body to our lab. We cannulate the carotid arteries and jugular veins, and we clean slowly, meticulously all the clot which is inside the blood vessels of the brain without opening the brain. And this process, it takes about 2 to 3 days. Then we will, this is how what I am having in the hand is the patients who already been washed from after cleaning it. And that is a carotid artery which I'm showing. And we cannulate like that, reverse the head and wash it, so that we'll inject the glue into red as a artery, blue as a vein, which will go to the distal part of the brain, and we call fixing the head. And then we store that in the ethyl formaldehyde, and then we'll open a small opening at the end of the week to see whether the distal part, this is just below the skin, below the skull, whether the blood vessel has taken up that blue color and the red color to suggest that my injection technique is appropriate. And then we sit under, this was my lab. This is the microscope, exactly what we use in the operative theater. In the lab, I used to have the endoscope, microscope, drill, high-speed drill, everything. This lab was costing, at that time itself, about $1 million in US, because I studied in one of the best institutions. And we will dissect the anatomy at every nook and corner so that I'll become perfect in anatomical skill. Then to harness that, I started teaching way back in 2000. I teach across the country, cadaver workshops. I do both endoscopic and microscopic every year. And by repeatedly teaching, it not only helped others, it helped me immensely. It helped me so much that as of now, any anatomy I can enter without much of the problem. And this also requires a lot of technology. The microscope I'm seeing, this is done, actually our own operative microscope. I had brought it inside our theater region, created a 5 cadavers. We brought it from the Bangalore Medical College and demonstrated to many young neurosurgeons across the country. And all these things, we had to then wash it, clean it for nearly about 10 days so that we can take it back to the operation theater. But many centers in the world, we will have a separate microscope for the cadaver workshop and separate drills and everything from the, from compared to operation room, because these things should not be used together. But because these are highly expensive, these drills are pneumatic drills, which will not have the torque. So it will not jump when I drilling this skull. Otherwise, once it jumps, even a millimeter, some of the nerves and the brain will be in my drill. So it has to be so precise. So that's why we use nitrous oxide drills, and which will not have a torque. It will not jump when I'm drilling. So these also requires a technological innovation in India, how to make all these things a cheaper variety in India. So teaching is the way we all learn and unlearn ourselves. So which are the technologies made the difference to neurosurgery? Numerous. I can tell you the diagnostic technology, like what you all see, CAT scan and MRI for the diagnostic purpose, and we call DSA, that is a digital subtraction angiography, PET scan, CV Doppler, those are the diagnostic technologies. In the operating room, microscope is the most important equipment for me. In fact, I keep telling everybody, even if my wife is not available, doesn't matter, but my microscope should never be spoiled in my operation room. My microscope I never share with anybody. It costs nearly about 4.5 crores, but it is the life for me every day, and it gives me the horizon picture when I watch through it, and indirectly it gives me energy to work on that. I will show you how my microscope looks. CUSA is the ultrasonic aspirator. We use it for tumor removal, and we use ultrasound and the high-speed drill, as I said, and occasionally laser technology. So, and the micro Dopplers. So in the operating room, it made enormous difference. All these things are available in my OR as of today. So monitoring technology, as I was telling you, today morning I was operating a patient on the speech area tumor, and I require a stimulating part. So I kept the patient completely awake. We have a different methodology of anesthesia. I think anesthesia also has developed parallelly with our technologies, because nowadays we fix the head and everything under frame. Many of these patients, we give local anesthesia there, and when we're operating, they should know the procedure. At the same time, they should not know. Means we have some kind of a sublime conscious level we take them. So whatever I will be talking, they will respond very well. But most patients post-surgery will remember only few things, but they will not remember the whole event. Otherwise, it is scary for them, and they will not cooperate. So these monitoring technologies helped us in that way. Intraoperative monitoring, we call it as a image guidance systems, awake craniotomies, and intraoperative CT and MRI technologies. And in addition to that, the away from my field, like radiotherapy, radiological field, as well as the chemotherapy field, also worked parallel with us, and they also advanced. And as of now, my operation theater this is a picture from my operation theater, one without anybody and one with me operating under microscope and intraoperative CT. On the left, you can clearly see, the light is falling on the patient's head. Patient is turned to the one side, and the microscope which you are seeing, depicts where exactly I'm focusing. And there is a big monitor where my nurses will watch how to assist, and also assistant will be seeing. There will be 6 eyepieces, and 4 eyepieces will be meant for our fellow neurosurgical trainees to look through the microscope, because they have to stand and look through that till we finish the surgery. And on the left extreme corner, we have what is called as the image guided technology, where we have a LED based technology. The frame will be fixed on the head, LED leads will be fixed, and also on every instrument there will be LED focusing. This thing will be available, glions will be available to us, and the camera on the left side, once it is focused, it will show with respect to the head where exactly I'm positioning. So most of these patients, we will do, and before the surgery, a thin slice of MRI or a CT of the brain, and we reconstruct the tumor and the image guidance will be fed with that CD, and that converts it into 2D and 3D pictures. So when I'm operating and the microscope is integrated with the image guidance, and when I'm going through the microscope, it will also show where exactly I'm focused under microscope. So I get 2D, two-dimensional picturization of my focusing area, so that the precision improves with the surgery. So these things which are not there about 20 years ago, in fact, I'm the first person in the country to do both brain and spine surgeries using the navigation technique. As of now, it is available in many centers. And to be frank with you, India is one of the best country for neurosurgical procedures. We have wonderful neurosurgeons in this country, and the number of experience we have is compared to any other part of the world, we're extremely good. Only thing we require is some PhD students to come analyze, work with us, our work, and learn from it, and also propagate the word, so that we will have many people coming to India rather than people going westward. As of now, people are looking eastward, because now I have fellows coming from Japan and every places to learn rather than we going there. So that's the beauty of it. On the right side, you will see me operating on the brain tumor. The big screen shows the tumor has been removed. There is a cavity which you are seeing. And the white thing you are seeing is the cotton patties we use, so that the brain, when we are retracting, will not be, the normal brain will not be injured. And on back of me is the big, another body term is written there. So that is the intraoperative CT scan. So at the end of each procedure, we do, when the patient is on anesthesia itself, another scan to doubly confirm that whether adequate amount of the tumor has been removed. If not, we continue our surgery. So that on the table itself, we can completely diagnose the way. Excuse me. This is available in only few centers in the country. Once again, our center is the first hospital to have it across, compared to anywhere in the India. So we use it day in and day out. So the operating microscope beauty is it gives a 3D magnification to us, and it differentiates the normal tissue versus the abnormal tissue very well. And we also get the comfortable position, when operating. You can see here on the right side, I'm operating. On the left side is my resident. He is a neurosurgeon now in US, and he can also see every step what I do, so that they will understand, including the depth perception and the touch. We call it as the touch is such an important aspect in neurosurgeon. We feel everything based on the touch, not by the feel. So, for example, consistency of the tumor and the tumor dissection between the normal and abnormal, we deal under the microscope. In addition to the magnification, is about how the tumor feels in my fingertips, even though I'm using the instrument far away from me. So that the connection between the instrument and me is so important. It makes enormous difference to us. And we also have video system and documentation where we can retrieve that. Students can learn. I can retrieve that and relearn if anything mistake I have done, or it's also available for research purpose. So there is a lot of world looks different under microscope. I'll show you one of those things they call STA-MCA bypass. Means we use a blood vessel for a stroke patients, especially childhood stroke, where we take the blood vessel from the just in front of the ear, and we pass it into the brain to add another, we call bypass, give extra blood from the skin to the brain. And to do that, it needs a high magnification. You see here under the microscope, you can clearly see the brain there and the blood vessels which are dissected from the skin. I have pulled it now inside, and next we are measuring how much to open in the blood vessels inside, about 1 centimeter only, and the diameter of this blood vessel is not more than 1.6 millimeter. So it's a millimeter level. So that has to be anastomosed, and we clamp it, and then we anastomose. You can clearly make out at the end of the surgery, when we do a CT scan, on the left side, you can see skull opened with the 4 holes, and the pink color, what you're seeing is the blood vessel I have pulled from the skin level into the brain. And it shows that the pathway has gone very well. And whenever I inject the dye, even from the skin, it goes into the brain. And this patient had a difficulty in speaking. And at the end of the 6 month, he was about 5th standard. He has word difficulties purely because that area of the brain had a lack of blood supply. When we added a new blood channel to that, because there's a stenosis at one level, we added a new blood vessel. To be frank with you, he is now studying in 9th standard and doing extremely well. So this is another image guidance which I told you, the picture of the body town which we use. So I'll show you a small video which will explain most of the things. This is the image guided one. He's of one of the companies. He had a brain tumor. This is how we position the patient, and that is the image guided glions you can see there. And I'm touching different parts of the brain to make sure that the direction, this is how it is. Wherever I touch, it will show the tumor and which area. This is the tumor on the right side, and the deeper part, you can clearly see a black area. So I'm using that even in the surgery to double localize where exactly is the tumor. So it is clearly showing that I'm in the right area. So this is the operative field. It will be far away from me. Those ball kind of things are called glion. There's LED ones, and green color shows I'm in the depth of the tumor. So as you can see, I'm microscope moving. It is showing which are all the parts I'm removing in the tumor. See, this is under the microscope. That is a tumor. I'm removing it bit by bit. And once we remove that, every area, and I go back, this is under the microscope, we are cutting that area. And as I remove the tumor, the navigation will show that I have removed most of the deeper part, and I have reached even the most deepest part of the tumor, so that the patient, so you can see the track is this one, and the next day patient is walking. Believe it or not, he was, he went on the next day. This is yet another patient, very interesting patient. This patient, I'm doing the surgery, keeping him awake because it is the deeper part, supplying one-sided hand and leg area. He is just about 26-year-old IT professional, brought by his girlfriend, not by anybody, because he had a fits in the during his work hours, and they brought him directly from his office, and we found him having a tumor. And after digging all the history from him, we got to know that he used to get this a few years before. At that time, he was investigated at Velo and had a tumor in the deeper part, because they explained that he cannot, after removing the tumor, he'll become weak on one side, leg and hand. They refused surgery, and they've continued with Ayurvedic treatment, homeopathy treatment, only to have recurrent seizures to him. So I did this patient because in the deeper part, I had to find out where is that hand area, where the leg area, because in the naked eye and in the microscope, inside the brain, all the tissue looks alike. So you cannot make out the difference at all, but only with the stimulation of the areas in the deeper part of the brain, we get to know which is hand and leg area. So for that, unless we keep the patients awake and he responds to us, how he behaves, we cannot make out. So I will show you this video. This is also less than 2 minutes, and it will also show what all technologies I have used. He is a young man, very smiling, happy guy, but he wanted surgery only from us. He went to multiple places, and he had no problem before the surgery except repeated fits. Every 2 days once he used to get the fits. And that is a tumor in the deep part of the brain. This is the axial section, which is showing that there is a large tumor in the middle of the brain. You see any direction, it will have it. We do what is called functional MRI. So we ask the patient preoperatively move his hand, finger, and area. So MRI picks up those areas. All the yellow areas which you showed, which you seen earlier, are the functional areas. And we did a intraoperative CT scan for him. That's the same body term I use to see before and after the surgery how it looks. And this is the CT scan. You can see that the white part is the stone part. There is a calcific part of the tumor. So I'm opening here. A small opening was done. And after opening the skull, that's the brain. And I use the depth electrode to measure the waves of the brain. These are the epileptic waves. And this is a radiologist. I'm using the ultrasound here too, because on the surface there is nothing. So under the depth, you can clearly see using the ultrasound that there is a change in the sonic character. So that is a part of the tumor. So you can clearly see here the difference between the normal and abnormal tissue is almost zero. Only with technology, only with my experience, I can see where exactly is abnormality. All those are small blood vessels, and we coagulate those things using bipolar cautery and using the ultrasonic waves. We don't dig the small opening we do, and then we bring in the bipolar cautery again to open it. Under heat generator, only tumor usually takes it. This is called ultrasonic aspirator. So it just, you hold it, ultrasonic waves will go and take out the tumor tissue, and those tumor tissue will be sent for biopsy for us. And slowly I continue this till I do the, once again, in between, once again, I'm using the ultrasound here on, so you can see here, I have to remove most of the 3/4 of the, this is the ultrasound again. So I have gone, all the black area you see in the middle are the amount of the tumor I have removed. All the white area at the edge, what you are seeing, the white area here are the, the tumor, and the deeper part is the tumor is still there. So this is the area where I had to be extremely cautious, because if it is about 2 to 3 millimeter from the water area, the black area which was seen, earlier in the MRI was nothing but CS of space, and it is very close, and I had to preserve this deeper part, then only he'll become all right. Otherwise, he will develop one-sided complete hemiplegia, we call. So So we continued digging the deeper areas, and we extended that because some more tumor was there. And once again, use the cursor multiple times, and at the end, it becomes everything clear. Every blood, even one dot of blood also, we normally coagulate. So no RBC should be seen at the end of our procedure. That is the way neurosurgeons usually perform a surgical field. And then this is at the end. When I put this saline, it should look clear. Once again, I am doing the ultrasound, and the ultrasound, you can clearly make out whole tumor tissue has been removed. And we use the CT scan to double confirm. I've gone to the depth in a small track of 1 centimeter, not more than that. This is immediately after the surgery, within 15 to 20 minutes, and he's walking. And this is the question mark. Unfortunately, I had to put a question mark for his life. He's doing very well, and he went home within 3 days without any problem. So that's how the technology helps. This is yet another technology we call biplane machine, where we use it for coiling of the aneurysms and the AVMs, where it rotates in 360-degree and gives us the technology to enter the blood vessel related problem, where we need not open the skull, and we go through a small catheter is passed through either your brachial artery in the hand or iliac artery in the leg, like how we do the carotid, the cardiac angiography, we do in the cerebral angiography. And small, micro catheters will be there, 0.01 millimeter, 0.02 millimeters, catheters, which will go and put a small spring into the aneurysms. I'll show you how the technology works. This is this is called coiling of the aneurysm, where this is the aneurysm, which is blood, which ruptures with a high pressure, and most patients usually come with a severe headache, and some of them succumb in the night itself without, they don't even come to the doctors. And this is a coil technology. Catheter is going into the aneurysm, and a micro catheter, is passed into that. We put the coil into the aneurysm, and the aneurysm closes by itself because of the secondary coagulation. So you can see there, we are passing a small guided catheter, and this shows the aneurysm is seen here. And the coil will be pushed now, and we are pushing the coil into the brain, and see how partially it is closed, but still we are continuing the procedure. The whole procedure takes about 2 hours. And at the end, when we do, rest of the blood vessels are seen. That aneurysm which was looking, it gets thrombosed, so it will not be seen. So this is the microcatheter. You can see small thin line which is going. At the end of the procedure, aneurysm is not seen. So most of these patients we send home on the next day itself, because this technology was not available when I was a student. Now it's a world standard one, and our center is one of the most, when you do the skull X-ray, you can clearly see the right one. So this is the patient, you can clearly see right side leg and hand, she's not moving. And on the next day, she walked home, with completely normal, other things. If you do open surgery, many of them will get stuck in the aneurysm surgeries for weeks together. Luckily, she's doing she has done very well with her coiling procedure. So we also use, for the biopsy purpose and everything, we fix the frame, and we use the frame-based precision surgeries. So it is a fiducial we use, and it's a phantom. You can clearly see the phantom is here. So it mimics the skull and the target we are having, and then we do the biopsy. So literally speaking, from the time I started the residency program till today, we have brought it to almost a daycare surgery. I do surgery in the morning. If the patient pain is tolerable to them, many of the people, especially coming from the village with a low economy, they tolerate the most of our surgical things, pain very well. And within next day I can discharge, which becomes very cost contained, which is the key. And that's the way I worked all my life, and so is my team, because the neurosurgical procedure costs humongous amount in the rest of the world. In fact, India is one of the cheapest, and our hospital is one of the cheapest for the kind of the procedure we do. And we are one of the cheapest neurosurgeons in the world, but we love our work. We do have, we participate with the NGOs and everything. We help everybody who comes to our hospital. So one of the ways why we got trained so well is to do the cost containment and send the people back to their work at the earliest. And it also reduces the infection rate to the patients, and also occupancy of the ICU comes down. Overall, the patient benefits more because of the precision in which surgeon and technology works. So surgeons' experience and training is very crucial in neurosurgery, in addition to technology, as I mentioned. So more the experienced surgeon, lesser the duration of the stay to the patient. Better the trained surgeon, more the scope for the improvement for the resident, as well as he will always practice the improvement skills set we try to improve every time. And we use what is called minimal invasive technique, means less destruction of the tissues. So that makes enormous difference to patients. These are the few examples of the tumor. We call it as a cavernous sinus, which used to be called as no man's land, because all the blood vessels and nerve. On the left side is the tumor, right side of the tumor is removed. This is another one. You can see sagittal picture. You can clearly see that means the nose is in front, head is in the back, and the neck is extended down. There is a tumor at the brain stem, and there is a post-operative one on the right side, which is completely removed. And all these patients were sent home within 1 or 2 days. So in conclusion, neurosurgery is a technology-driven field, and the technology and the surgical skill adds to final outcome of the patients. And I'm sure in future, AI will improve preoperative, intraoperative programming for us. Single neuron stimulation technologies will be the future, because I had to stimulate every neuron to make sure that, like for example, in cases of Parkinsonism, in case of epilepsy, we had to find out which neuron is, firing abnormally. So that technology is still not come. I'm sure with the new AI technologies, if we use the preoperative MRI, functional MRIs, and the PET scans, we can make out which is the abnormal one. And I'm sure within next 10 years, technology makes precision and safety of the patients much more better. Similarly, I'm of the hope that one of the best ways of detecting dementia and stroke, because here there's no treatment available once it happens. So early detection, for example, a 40-year-old man, as a professor recently came to me, and he's a PhD holder, multiple education he had, but unfortunately he's a loner, and he has written multiple papers and everything, but he was never mixing with anybody, asocial element, and the family started noticing a sudden dip in recent memory. So when we did, we found a typical Alzheimer patches within the brain. But had we done about 10 years ago and told him, what all the, ultimately, your mobility, your social interaction to stimulate the wider part of the brain is the key for the dementia. In fact, as a normal human being, we don't even use half of the brain. So imagine there are about 360,000 billion neurons available. We don't use it completely. So when you don't use it, as the age progresses, it will become redundant and the interneuronal connections comes down. That's why few people who are, not just, being a bookworm, or only if you are doing things which are highly skillful will help. Social connect, the human brain is given for multiple purpose to stimulate different parts of the brain, because each part of the brain has its unique physiology and anatomy and the function. And unless we stimulate every part, the chance of dementia is higher. So is in the, in the stroke. If you don't contain, hypertension, diabetes, hyperlipidemia, whenever these diabetes, when these things are there, if somebody does every 4 years once during his hypertensive period, AI might predict that he's a future candidate because it is not giving enough blood at particular small area of the brain. So that is how the technology should develop, so that we predict well ahead. I think, I'm sure in few years it will come, and ours and your institutional tie-up will take this, to take it to the next level, so that multiple brains works can makes enormous difference. And I request to all of you to come. Let us embrace the future and work together, so that it makes enormous difference to all of us. Thank you very much for the patient listening. I don't know, I put some videos only to make you understand some of the technologies we use, but it is very difficult for me to explain neurosurgical procedure in 1 hour. Thank you very much.
Thank you, Doctor. Professor Srinath, would you like to speak?
Thank you, Dr. It's a wonderful talk. So anyway, for the benefit of the audience, maybe I should also let them know that I have been under the expert hands of Dr. Rudrappa recently as well. So he operated on me about a month ago, and I can vouch for many of the things that now I was walking in just one day, like you mentioned. So this was this really kind of experience the state of the art, where how you mentioned that how it reduces the cost and brings about overall benefit and so on. So I think it's a very wonderful opportunity and a wonderful initiative that you are taking up. And I think both IT, information technology, especially, I did ask some question on AI and data science and so on. I think there is a lot of complementarity. So some of the research that happens in both embedded systems, data science, AI, and so on, can probably help out in both the surgery as well as peripheral activities. So it would be very interesting to explore further, and EHRC will take the lead. Professor Srikanth and Jaya would probably take the lead, and all the support from the institute would be there from my side. And so thanks once again for this very wonderful talk. And we have a lot of questions over there. Sure. So probably I'll stop at this, and maybe Jaya can take up some of the questions.
Thank you, Srinath. I look forward for the collaboration.
Thank you so much, Doctor. Round of applause for you.
Thank you.
So one of the questions was on which of the equipment is indigenous, and to what extent the brain is able to sense surgery being performed.
To be frank with you, I have less than 1% of the equipment which are indigenous. That's why I'm giving this talk. To be frank with you, it's painful even to me, because the precision in which the instrument should be done and the technology should be done has not come to that level. And we all should now look at how to make the quality products, which will be world-renowned way we had to do it, rather than for having done some new instrument coming up. So as of now, I have very less than 1%. Coming to your second question, how this brain is painless, but the skin, the covering of the skull, and also the covering of the brain is highly painful, because it is holding an important structure in the brain. So as long as we keep this 4 layers painless, I can enter the brain. That's why I showed you the awake craniotomies. All these patients, nowadays, I do a lot of, I'm one of the highest person, surgeon who does the highest number of awake craniotomies. We do it
Right.
especially for the important areas because it also reduces chest infection. It also reduces being on a ventilator patient, and also it reduces the cost. And the patient will be as fresh as now before the surgery at the end of the procedure. So these are the great advantages. And I do awake surgery by suppressing the pain at the superficial levels of the skull.
Right, right. The next question is on the use of thermal camera for finding tumor. Are thermal cameras used in
No,
brain?
we have no. We use ultrasound mainly.
Okay. There's a question on the total cost of the surgery. So it
the
is.
the the cost of the surgery, I told you, it's one of the cheapest in the world. It depends from one procedure to another. For example, a brain tumor which I showed you, that the young boy with all the technology used is about I think 4 lakhs to 4.5 lakhs. That is
Okay.
closer to about less than $8,000. In US,
Right.
even a MRI cannot be done with $8,000.
Okay.
And surgeon charge was $100 or $200.
Right. Right. So when you cauterize capillaries during the surgery, does it impact the neurons supplied by these
Yeah,
capillaries?
absolutely, yes. So that's why we should know which part of the capillary is coagulating, and which is the area which is involved by the tumor. Only that part of the capillary we coagulate. Otherwise, we don't do the wide area like abdominal surgery. No,
Okay.
we have to be
And how
very
does
precise.
the brain heal itself after an operation?
Because the beauty of the brain is the tumor occupies the place and it pushes the brain to the periphery of the tumor. So when we remove the tumor, it collapses back, and the only track will be seen. The rest of the brain will be normal.
Okay. Does it have anything to do with the neuron regeneration? Does the neuron regenerate itself?
That's why we enter the area which are not so functionally viable. In
Right.
the sense, the brain also has a lot of glial cells. Glial cells is nothing but a supporting cells. A good
Right.
surgeon will know how to dissect the plane between the tumor and the normal tissue.
Oh,
So that's why we require precision into this. Not
oh,
every neurosurgeon, even a new graduate or a person who is a 5 years experience, can do that. But it requires a kind of a skill to understand which one he has to pull and push, and to take out the tumor easily without causing a problem to neurons.
right. The next one is, does uncoagulated blood during surgery cause any damage?
We make sure at the end of the procedure everything will be washed with the saline, so clean that you put the water, it looks as though it is in a tray. So yes, it does cause, because iron, the blood has iron. The
Mhm.
hemosiderin is epileptogenic, so we
Okay.
don't leave much of the blood and blood products inside the brain.
Okay. Okay. There's a question on data privacy. Is it okay to show the names of the people? But you had mentioned it's okay for educational.
No, no, we always take, especially the patients for the education and everything. We
Mhm.
normally, take the full
Take
consent
consent.
of the patients, and
Mhm.
then we show it. But most often, except the research, but if you show it to the common man, we always take it out everything, including closing the eye of the patient. Everything we do it, but only for the medical education. And ours is also, we are now looking at how to involve the students into this. That's why I opened it. Otherwise, we close everything. We put the
Okay.
uh,
Okay.
privacy is very important for us.
Right. Okay. Another question is on potential research opportunities for image processing and data science methods for aiding neurosurgery.
Correct.
So I guess you had
Definitely is there.
mentioned about pre-operating and
Correct. Correct.
intraoperative, right?
Correct. We do have enough of data within the hospital, and we do, as I said, our radiology system and our operative places. We have collected the humongous amount of patients' detail who have been done for last 6 years. So if somebody does this, sure, it will be makes enormous difference.
Right. Right. There's a question on how much of the functional connectivity of the brain do you work with? as a surgeon dealing with structural level, how do you deal with the functional aspect?
Oh, we are looking at the functional aspect. So if I remove the function of the patient and remove the beautiful tumor, obviously, patient will be in trouble and I'll be in trouble.
Okay. Can all forms of epilepsy be cured by surgery?
Not all forms. There are, we call uh, about 10 to 15% of the patients, it starts from some areas of the brain which are formed as scar, either by congenital or by repeated seizure episodes. So if we find out where is the origin of the epilepsy coming, with PET scan, MRI, and we do what's called as um, awake EEGs. Video EEGs we do for about 24 to 48 hours. We withdraw all the medication, we induce the epilepsy, and we record those things, and immediately we do MRI and PET scan. All three things should show that it is originating from one place. It is like origination of Kaveri. If it's if you block the Talakaveri area, Kaveri will not. Similarly, in the brain, if the epilepsy is coming from a focal area, if I remove that area, epilepsy will not happen. Yeah, but it gives a tremendous result to the patients. I have innumerable patients. Their life has changed.
Okay, yeah. There's a question on how to become a neurosurgeon, a third-year medical student.
How to become a neurosurgeon? Dream, work hard.
Okay. That's a good mantra.
Yeah, nothing else. Yeah. But it should be a daydreamer, not a night dreamer. Only a daydreamer we can make it, happen. A night dream will never.
Right. Then there's a question on a single neuron level as a futuristic technology that's yet to come, right? So what is the state of the art?
We do, for example, now we do what's called deep brain stimulation for multiple purpose. That is a future for chronic pain, Parkinsonism, and I'm sure, it's a focal epileptic focus and everything in the longer run. The technologies are coming closer to deep brain stimulation. So at the micro level, we record it for hours together. It has come, but it requires user friendly, and more people can use it. More neurosurgeon can adapt. So as of now, the functional surgeries are adapted by very few people because it is much more complex. Learning curve is longer, but the newer technologies, especially in US, has come forward significantly. I'm sure in maybe in 5 years, we will have many things coming up.
Right. Okay, so there's another question from a student, our student who's from Indonesia. He's asking, for a social scientist, what is a good way to enter into neurosurgery, and what are good keywords for communication disorder study?
Communication disorder study. The social scientist means a scientist who works towards the society, right?
Right.
Okay. So as I said, I have recently started the EPIC program as a social scientist by myself. It has been inaugurated by Chief Minister about a month ago. Here, what we did is, because epilepsy usually affects the low socioeconomic strata people many places, because of the febrile seizures in the childhood, because of the repeated upper respiratory tract infection. And most of these children and adults, they cannot afford the anti-epileptic drug in the beginning. They will have repeated seizures, which have a significant socioeconomic problem. One in the form of poor education, their concentration capacity comes down, and some of the epilepsies are missed, thinking that the child is doing something else abnormal in the class, but not concentrating. It might be an epileptic fit itself, where he'll behave abnormally, run around in the class, and they come back and sit. They think that it is naughty, but it could have been a seizure. So at the same time, we have seen women divorcing because of the epilepsy, women committing suicide because the other family has not been told before the marriage that she had epilepsy. Fifth, I have seen multiple abortions happening because the anti-epileptic drug the child, the women are already on for the epilepsy. So knowing this, social problem, this year we started this EPIC program, where we have came out with an app which can be downloaded as EPIC, EPIC-Rotary. Along with the Rotary, I involved Rotary into this, and so that every Rotary club will increase the awareness about it. And also, if any patient who requires surgery, to be sent to us so that we will do free surgery for next 2 years. So, this is the way I'm putting my neurosurgery into the social background. So in that way, many patients, for example, dementia, there is a lot, in fact, my son has done what is called as uh, connecting the old people, because in the modern day, many children will be 1 or 2, and I find a lot of elderly people coming, and most of them study like you people, IIT and everything, and they leave the country, and the old couple will be left here in Bangalore and the village. So they develop dementia. There is no social connect. So for that, the young chap started a new channel called as Let's Talk, where the youth in and around the community can they can adopt 1 or 2 elderly people in and around their place and meet them 2 hours in a week and chit chat about with them whatever you think, so that their brain remain active. You learn from something from them, and you also give back the physical. For example, if they want to go to bank or somewhere, you enact and show, and also help them. So that brings the communication. The communication improves, the dementia comes down, and their loneliness comes down. So these are the social related issues which can be taken from the neurosurgical point of view.
Okay, okay. There's a question on LED-based guidance system, which is required for any fiducials to be placed during pre-surgical imaging,
There are
or
two
is it
varieties.
based on intraoperative CT?
It's an intraoperative. There are two varieties available. One is we used to use the fiducial based one, which has been given up now, non-fiducial based now. Surface marking on the skull itself will be, on the face itself will be taken. Now most of the things we do is non-fiducial based.
So there are two more questions, and we'll close after that. So one is some problem statements where you think technologists can help in neurosurgery, and the second one is on the use of augmented virtual reality for surgical training. So
Yeah.
we like to
Now,
comment.
both the things, for example, augmented training, it is available in the rest of the world, but it's not available in India yet. Even in the government setup, where the places like AIMS and everything, which is considered the premier institute in the country, where government spend lots of money, which is not available. Sure, it can be doable, which makes humongous difference to training program, because most of the neurosurgical trainees are not given brain directly to them because they cannot experiment. As I said, it takes about 10 to 15 years to skillful surgeon. They need these kind of the things to make sure they will learn better. So definitely AR and AI will, if the new technology comes, we can mimic the surgery and they can get trained in the labs, which will have a humongous impact, and India can be the leader in that. The first question, what is that you said?
What are some of the problem statements where
Yeah.
technologists can help?
See, for a problem statement is especially the brain is, as I mentioned, if I see a tumor, the tumor will have different characteristic in the different parts of the brain, different within its own confinement. So some areas will be highly aggressive, some areas are less aggressive. So those things we cannot make out with the available present technology like MRI and PET scan. So if the AI or something with the data analysis, if you do, taking that as a whole mass, and you do the computing system and mathematical analysis, if you do and see some areas which are malignant, I can take the biopsy from there first, so that I will not miss because the treatment changes, treatment algorithm changes. So, and the prognosis changes and survival changes. So that's the reason I'm now talking to you people, so that we can work on these kind of things, which is still in the primitive stage in anywhere in the world.
Okay. Thank you so much, Doctor. It's a
Yeah.
valuable 1 hour of your time.
Thank you.
Again, thank
Thank
you
you
so
very
much.
much. Thank you.
Shrikant, would you like to say?
Big thank you, Dr. Satish Rudrappa. I think it was a wonderful talk, very informative.
Hopefully, you people understood what I said.
Oh, I'm sure.
Yes, we do.
I mean, some of the pictures might have been scary, but I'm sure they understood.
Yeah. That's why I took
But I think this
biology.
was very well done talk, and I think it was actually you explained things very well. So let's hope we can start working together and identifying areas of
Yeah.
collaboration.
So that's what I'm looking forward, because we shouldn't leave it at this point, but because there is a lot of opportunity to young people. As I said, my institution, my department has good number of fellows and residents, and if a IIIT student, somebody from the first year comes, spend 2 to 3 years within our hospital as your student. Now I will make the arrangement so that that is the future to go. India should open for these kind of things, which was not seen before, and none of the government hospitals will do. But the beauty of the private hospitals is, you will be welcomed at any time. No bureaucracy, no red tapeism. Things can work very easily.
Okay, thank you.
Thank you so much, Doctor.
Welcome. Yeah.
Thank you very much.
Thank you very much. Thank you very much.